So next is femoral hernia. It's V17. You are asked to see a 73-year-old woman who has presented with vomiting for the last 2 days. She has been admitted with the possible gastroenteritis. What you will do? So I will take a history when this vomiting started, what's the frequency of vomiting, what are the contents of the vomiting, anything associated with the vomiting like abdominal distension, abdominal pain, any previous surgery, any lump on the abdomen, any recent change in the bowel habits, bleeding per rectum, and the any blood per rectum, and any weight loss, any other medical problem, allergies, family history, surgical history. Then I will examine her uh, heart rate, blood pressure, temperature. Is she dehydrated? Is there any obvious abdominal distension, any abdominal scars from previous surgery, visual peristalsis, signs of peritonism, palpable mass, any groin swelling, and I will do a per rectal and per vaginal examination. She should have a full blood count, urine electrolyte, ECG, and a plain abdominal X-ray. She has given a Vision abdomen with a palpable tender left groin swelling. What is the most likely diagnosis? An obstructed left groin hernia. Given her gender and the age, it's likely to be femoral, although it could be inguinal. How would you differentiate femoral from the inguinal hernias clinically? So all inguinal hernias are above and medial to the pubic tubercle, and all the femoral hernias are below and lateral to the pubic tubercle. And in non-obstructed cases, inguinal hernias are generally soft, reducible, and have bowel sound, while the femoral hernias are generally firm, irreducible, and lack the bowel sound. What is the more common in femoral or inguinal hernia? Though inguinal hernia is most common in the females, but in emergency, femoral hernia is the most common type, of which present with incarceration and strangulation in the ED. Why are females most likely to develop the femoral hernia? Normally, iliopsoas muscle has a good bulk and act as a barrier to the development of hernia. Aging, atrophy, the muscle mass, and wide pelvis in women make them prone to develop femoral hernia. What structures comprise the femoral ring? Anteriorly, inguinal ligament; posteriorly, iliopeteneal ligament or pectineal ligament; medially lacunar ligament; and laterally septum and the femoral vein. How will you manage this patient? She will need intravenous nil by mouth, IV access fluid, antibiotic analgesia, DVT prophylaxis, pass an NG and catheter, and consenting and reading for the theater. So outline your surgical approach: out spine position with NG and Foley's in situ, antibiotics, modified financial 2 finger breadths above the inguinal ligament. This is modification of McCavity's NCN. This can be converted to laparotomy if bowel dissection is required. The external oblique is divided vertically at the lateral edge of the rectus sheath. The rectus muscle is retracted medially and the preperitoneal plane is entered. The inferior epigastric arteries may be sacrificed. Blunt dissection in peritoneal plane exposes the femoral canal and access to the femoral ring from the above. How will you release the constriction? Blunt dissection with the artery clip or divide the inguinal ligament or the lacunar ligament medially, and the risk of injury to the accessory arterial artery is about 20%. What other approaches can be used for the Lockwood approach or low approach? Use an elective hernia repair. Use mesh plug to close the ring and approximate inguinal ligament to iliopeteneal ligament. So inguinal and pectineal ligament. Transinguinal approach or Lothison's approach through posterior wall, less favored, and laparoscopic approach, tap or tap. Short posterior stay, low recurrence rate but higher incidence of bowel injury. How will you decide if the small bowel is caught as health? So 3 P's: pulses, peristalsis, and pink color. Thank you.